Welcome to the Funnel Effect. Today, we are embarking on a really high-stakes deep dive into a corner of cardiology that is just notoriously complex.
Yeah.
We're talking about the distinction between two conditions that can look almost identical but demand radically different life-altering treatments: constrictive pericarditis and restrictive cardiomyopathy. Our guide for this is a fantastic piece of scholarship. It's the state-of-the-art review, Differentiation of Constriction and Restriction, Complex Cardiovascular Hemodynamics. It was published back in 2016 in the Journal of the American College of Cardiology, volume 68, number 21. And the authors are a really distinguished group: Jeffrey Biexky, Nandan S. Anavikar, Rick A. Nishimura, and Bernard J. Gersh. So our mission today is to give you a clear roadmap for navigating what is really a diagnostic minefield. I mean, the stakes are just immense. You have constrictive pericarditis, or CP, which is a potentially curable form of heart failure
It's surgery. Yeah.
with surgery.
Yeah.
And then on the other side, you have restrictive cardiomyopathy, RCM, where the definitive treatment is often cardiac transplantation. So we really need to cut through this clinical overlap and get to the deep underlying mechanical principles. They're the only reliable way to tell these two apart.
That's the perfect framing for this. I mean, when a patient shows up in the clinic and they have this advanced, mostly right-sided heart failure.
So we're talking about swollen legs, fluid.
Yeah, significant peripheral edema, fluid congestion, their liver is enlarged. But, and this is the key, their left ventricular systolic function, their pump function, is surprisingly preserved. That's when these two, CP and RCM, they just jump to the top of the list. If you look at the patient from the neck down, they can look exactly the same.
And the high stakes you mentioned, it's not just an academic exercise.
No, not at all.
You're deciding if a patient gets a curative surgery or, well, faces a much grimmer prognosis that requires end-stage care.
Absolutely. The entire decision-making process boils down to one fundamental question. Is the problem external or internal? Is the impaired diastolic filling, the filling of the heart, caused by an external constraint on the chambers? That's constriction. Or is it because of the intrinsic stiffness of the heart muscle itself? And that's restriction. A clear grasp of the underlying hemodynamics, the physics of it, isn't just helpful, it's fundamental.
Okay, so let's start there. Let's establish the physical differences, starting with constrictive pericarditis. You described it as an external constraint, like the heart is in a vice grip. What does that actually look like?
Pathologically, CP is the encasing of the heart by the pericardium. That's the protective sac around it. But instead of being thin and flexible, it's become thickened, fibrous, and a lot of the time calcified.
So it's turned into a rigid shell.
Exactly. It's a non-compliant, rigid shell. And that shell acts as a physical restraint, just stopping the heart chambers from expanding fully when they're supposed to be filling with blood.
It's like trying to inflate a balloon inside a concrete box. The balloon material is fine.
Perfect analogy.
But the box just limits the total volume it can hold.
That's it, exactly. And a key concept, which we'll come back to, is that the initial relaxation of the heart muscle itself is often fine. It's just that the limit to the filling volume is absolute. It hits a wall.
And this isn't a new disease. The source mentions signs of it going back to biblical times.
Right, but our modern understanding really came together in the 19th century.
So what causes this? What drives this process? Does it vary depending on where you are in the world?
It varies a lot, which is a really important point for clinicians. Worldwide, especially in developing nations, tuberculosis is still the #1 cause.
Really? TB?
Yeah, often complicated by HIV co-infection. That chronic inflammation from TB leads to this massive fibrosis and calcification of the pericardium. But here, in the developed world, the picture has really shifted. We're seeing a lot more iatrogenic causes.
So caused by medical treatments?
Exactly. Post-surgical inflammation, especially after cardiac surgery, is a big one. And maybe the most significant one now is prior radiation therapy.
For cancers like lymphoma or breast cancer?
That's a huge driver of CP now. Of course, you still have idiopathic cases, connective tissue diseases, things like that. But that history of surgery or radiation is becoming a key part of the puzzle.
And the paper notes that the symptoms are insidious. They kind of creep up on you. What does that mean for the patient's prognosis?
It's a slow, progressive congestion. But the good news here, and this is the crucial part, is that this is the potentially curable form of heart failure.
Right.
A complete surgical removal of that constricting pericardium, a pericardiectomy, can lead to just excellent symptomatic improvement. It can often normalize everything.
But the prognosis isn't always great, even after the surgery.
It depends heavily on the underlying cause. Patients who develop CP after radiation therapy, they consistently have worse outcomes.
And why is that?
because the radiation doesn't just damage the pericardium on the outside. It often damages the myocardium, the heart muscle underneath as well. So the problem isn't purely external anymore.
So the mixed picture.
It's a mixed picture. And it's also worth noting, most clinical series show a strong male predominance for CP, though we don't fully understand why.
Okay, so we've defined CP as the external stranglehold. Now let's pivot to the other side. Restrictive cardiomyopathy, RCM, the internal stiffness. How different is the pathology here?
It's fundamentally different. RCM is a primary disease of the heart muscle itself. The problem isn't external, it's an intrinsic tissue abnormality. The heart muscle has become stiff, rigid, non-compliant.
The pericardium is fine in this case?
The pericardium can be perfectly normal, but the muscle fibers themselves, they just can't stretch and accommodate blood during diastole, during the filling phase.
And because the muscle is stiff, I guess the end result is the same. The heart fails to fill and pressures go way up.
Precisely. That stiff myocardium resists filling, which causes this rapid, sharp rise in ventricular filling pressures. And that pressure gets reflected backward into the systemic circulation, causing that right heart failure, and sometimes into the lungs as well.
And the pumping function is okay.
That's a critical feature. RCM is a diastolic problem. The left ventricular ejection fraction, that measure of systolic pumping power, is typically preserved until very late in the disease. The pump works, the reservoir is just inflexible.
The list of causes for RCM seems much broader. I mean, it could be any disease that makes the muscle stiff.
It's very complex. We usually break it down into primary or idiopathic RCM, which can be familial, sometimes linked to certain genetic mutations. But the much more common type we see is secondary RCM.
Where other systemic diseases are infiltrating the heart.
Exactly. And the number one secondary cause, the one we always think about first, is amyloidosis.
Where those misfolded proteins deposit in the heart tissue.
Right. And we now know there are different types like light chain or AL amyloidosis and transthyretin, TTR amyloidosis, which we're recognizing more and more, especially in older men. But we also see some of the same culprits we talked about with CP. Radiation heart disease and postoperative scarring are becoming more common causes in the developed world.
So radiation can cause both.
It can cause both. Then you have storage diseases like hemochromatosis, which is iron overload, or Fabry disease. Inflammatory conditions like sarcoidosis. The list is long.
If the problem is so deep within the muscle tissue itself, the prognosis must be a lot worse.
Unfortunately, yes. RCM is one of the most challenging types of heart failure to manage. We can give diuretics for symptoms, and if we can find an underlying cause, we treat that. But the stiffness often remains. For many patients, the prognosis is grim, and the only definitive treatment is often a high-risk cardiac transplantation. And that just highlights why this diagnosis is so critical. You can't send a CP patient for a transplant evaluation, and you can't deny them a curative surgery.
And this brings us to the biggest complication, the overlap. The paper really highlights that we often see a mix of both constriction and restriction.
This is the clinical nightmare. This overlap is most common after chest radiotherapy because, as we said, it damages both the pericardium and the underlying muscle. We call it radiation heart disease, and it frequently causes both problems.
The paper says the true prevalence is unknown.
The data is limited, but what we have is pretty sobering. One study found that over 12% of patients being evaluated had features of both. And the critical takeaway is their prognosis. Those patients had significantly worse survival than patients with just isolated CP.
Which creates a huge management dilemma.
A terrible dilemma. Do you recommend a high-risk surgery, the pericardiectomy, knowing that the underlying muscle damage might mean it won't help? It makes the distinction between pure CP and mixed disease just profoundly important.
Okay, let's move from the pathology to the physics of it all. Let's talk about hemodynamics, the language of pressure. But before we get into the abnormal, we have to really cement the normal baseline.
Absolutely. The key to this entire diagnostic puzzle is understanding how a healthy heart handles blood flow, especially during respiration.
And the effects of breathing are central to this whole deep dive. So remind us what happens during a normal inspiration.
Okay, so when you breathe in, your diaphragm moves down, and the pressure inside your chest, the intrathoracic pressure, it drops by about 5 to 10 millimeters of mercury. In a healthy, compliant heart, that pressure drop is transmitted perfectly to the heart chambers. And because the big veins bringing blood back to the heart, the vena cava, are mostly outside the chest, that pressure drop creates a gradient. It effectively sucks blood into the right atrium and right ventricle. So right heart filling goes up significantly during inspiration.
But the left heart doesn't see that same big increase.
No, and this is so important. The pulmonary veins, which feed the left atrium, are inside the chest, so they also feel that pressure drop.
So there's no gradient change.
Exactly. The pressure drops on both sides of the left atrium, so the gradient doesn't change much. Left heart filling stays relatively constant. The two ventricles aren't competing for space, and their systolic pressures just rise and fall together in parallel with breathing.
Okay, so now let's apply that rigid shell of constriction. If the heart is encased in this fixed volume, how does that just completely change the rules?
It changes everything. First, that rigid case isolates the heart chambers. They don't feel the full effect of those intrathoracic pressure swings anymore. And second, and this is the most important part, you have a limitation of total volume. The heart is in a fixed box. This leads to the equalization of filling pressures.
Meaning all the diastolic pressures, RA, RV, LA, LV, they all become the same.
They all tend to equalize, yeah, usually within about 5 millimeters of mercury of each other.
Okay, so let's talk about the specific pressure waveforms you see in the cath lab. We hear about the square root sign and the prominent U descent. What do those tell us?
They tell us about the speed of filling. They reflect this very rapid, unimpeded start to ventricular filling. The atria are backed up with high pressure, and the ventricle itself is still relaxed, so blood just rushes in. That rapid emptying of the atria causes this big, sharp pressure dip in the atrial waveform. That's the prominent Y descent. It's a key marker of very rapid early filling.
And then it just stops.
It just stops. It hits that rigid pericardial wall. So on the ventricular pressure tracing, the pressure dips down, but then it instantly plateaus at a high level. That's the classic square root sign, or dip and plateau. It shows filling being abruptly arrested.
The source also mentions an exaggerated X descent. Why is that specific to constriction?
The X descent reflects atrial relaxation and also the downward pull of the contracting ventricle. Now, because the external constraint limits the heart from expanding sideways, it overcompensates by contracting more forcefully lengthwise, up and down. That exaggerated motion pulls the atria down more forcefully than normal, and that creates an exaggerated X descent. This preserved or even robust X descent is a really important early clue that points away from RCM.
And now for the critical differentiator. Ventricular interdependence. You said in a normal heart, the ventricles don't really compete. What happens when you force them into a fixed box?
They compete intensely. This is the very definition of interdependence. When you breathe in, more blood flows to the right ventricle, but the total volume inside that rigid sac cannot change.
So something has to give.
The interventricular septum has to give. To make room for the bigger RV, the septum is forced to bulge over into the left ventricle, and that immediately impairs LV filling.
So inspiration helps the right side, but at the direct expense of the left side. It's a true seesaw.
It's a perfect seesaw, and this competition leads to two defining signs. The first is Kussmaul's sign. Normally, your neck vein pressure, the JVP, drops when you breathe in, but in CP, the right atrium is already under high pressure and can't expand.
So the pressure backs up.
It backs up. It can't accommodate the extra blood, so the pressure rises. A paradoxical rise in the JVP with inspiration.
And the second, and you said most sensitive and specific finding, is systolic discordance.
This is the definitive hemodynamic fingerprint of CP. Normally, systolic pressures rise and fall together with breathing, but in CP, during inspiration, the RV got more blood, so its systolic pressure rises. At the same time, the LV was squeezed by the septum, so its systolic pressure falls. The two pressures move in opposite directions. They are discordant. This beat-to-beat swing is just classic for that fixed volume constraint.
That's a perfect explanation. Now let's apply the same logic to restriction. If the problem is internal stiffness, how does that muscle respond to breathing?
The key here is that the intrinsic myocardial stiffness is constant. It does not change with respiration. The heart chambers are not isolated from the intrathoracic pressure changes.
So no dramatic competition.
No, RCM does not have that dramatic respiratory-induced competition or discordance that you see in CP.
But you still get those rapid feeling features, right? The Y descent and the square root sign.
Yes, and this is exactly why it's so tricky. Because the stiff muscle also limits filling abruptly, you still get high atrial pressure driving rapid flow. So you still get a prominent Y descent, and you still get the square root sign. For decades, this overlap caused a ton of diagnostic confusion.
So if those two signs are present in both, what's different about the RCM pressure tracing?
You have to go back to the X descent. In RCM, the stiff myocardium itself limits the heart's ability to relax and descend. It can't pull down on the atrium effectively.
So the X descent is blunted.
It's blunted or even absent. And that's in stark contrast to the exaggerated X-descent of CP. That's a huge differentiating feature on the waveforms.
Okay, we've laid out the complex pressure differences. Now let's see how much of that we can actually capture non-invasively. Starting at the bedside with the physical exam, what should you be looking and listening for?
Well, for CP, the physical exam is really a portrait of systemic congestion. You'll see distended neck veins, peripheral edema, sometimes huge amounts of fluid in the abdominocytes, and an enlarged liver. The two key signs we're looking for are Kussmaul's sign, which we just discussed, and the specific JVP waveform.
The prominent X and Y descents.
Exactly. You should be able to see both a prominent X descent from that preserved relaxation and a prominent Y descent from the rapid filling.
But the physical exam can be tricky. Kussmaul's sign isn't unique to CP, is it?
No, not at all. You can see it in any severe right heart failure. And if the patient is in atrial fibrillation, which is common, you lose the X descent completely. That leaves you with just the Y descent, which is shared by both CP and RCM, so its utility just drops.
And the physical exam for RCM, how is that different?
RCM also presents with severe systemic congestion. But a key differentiating feature is that RCM often has concomitant pulmonary venous congestion.
Ah, so fluid backing up into the lungs.
Right, because the stiff left ventricle can't relax to accept blood. So RCM patients will often complain a lot more about shortness of breath, dyspnea, whereas pure CP is really dominated by the systemic symptoms.
And the JVP contour in RCM.
It's crucial. You see that prominent Y descent, but you won't see the robust or exaggerated X descent that you see in CP. It's often blunted. You might also hear an S3 sound from that rapid rush of blood hitting a stiff ventricular wall.
Okay, moving to our first line of testing. What can the ECG and routine labs tell us?
The ECG is, it's generally nonspecific, but it can give you some suggestive clues. In CP, the inflammation can sometimes spread to the atria, causing these wide, low-amplitude P waves. In RCM, the findings are often more dramatic. You frequently see evidence of severe biatrial enlargement, so wide, high-amplitude P waves.
And there's that classic sign for amyloidosis.
The big one, the discordance between QRS voltage and wall thickness. The ECG shows surprisingly low voltage, but when you do an echo, you see these massively thick walls. That low-voltage thick wall combination is a huge red flag for amyloid.
What about BNP, the heart failure biomarker? Is that helpful?
It's elevated in both because both cause high filling pressures. However, RCM patients with their massive biatrial enlargement tend to have higher BNP levels, often over 600. CP patients are usually a bit lower, maybe around 200.
But the overlap must be huge.
The overlap is huge, and it's confounded by things like kidney disease. So we look at it, but we never hang a diagnosis on the BNP alone.
What about basic imaging, like a chest X-ray or CT?
The chest X-ray is mostly useful for one thing, looking for pericardial calcification.
Yeah.
You see it best on the lateral view. It's a great sign for chronic CP when you see it, but it's only present in about 25% of cases.
So its absence means nothing.
Means nothing. On the other hand, if the X-ray shows massive atria and a lot of pulmonary congestion, that points you more towards RCM.
And CT.
Cardiac CT is far superior for anatomy. It measures pericardial thickness. Normal is less than 2 millimeters. If it's thicker than 4 millimeters, that's highly suggestive of CP. It's also great for seeing calcification.
But you mentioned earlier that up to 20% of CP patients can have a normal thickness pericardium. That seems like a critical diagnostic trap.
It is a profound trap. We call it occult constriction. It means a thin pericardium on CT absolutely cannot rule out CP, and that's why you have to move beyond just anatomy and look at function.
And now we get to echocardiography, which is arguably the most important non-invasive tool because it bridges that gap between anatomy and hemodynamics.
It really is. On the 2D echo, the first and most universal visual clue for CP is the ventricular septal motion.
The septal bounce.
The septal bounce.
Yeah.
Because those two ventricles are competing for space, the septum has this pronounced shift. Leftward when you breathe in, rightward when you breathe out.
So you're seeing that interdependence live on the screen.
You're seeing it live. In addition to that respirophasic shift, you see the shudder, a rapid, abrupt movement of the septum in early diastole that just suddenly stops. That's the visual equivalent of the dip and plateau.
And for RCM on 2D?
In RCM, you're seeing the primary disease, so maybe normal wall thickness, but severe biatrial enlargement. Or in infiltrative disease like amyloid, you'll see that concentric increase in wall thickness.
Okay, now let's add Doppler to get flow velocities. Both conditions have that rapid filling pattern. How do you start to tease them apart?
You're right. Both have that E-wave predominant mitral inflow with a short deceleration time. The filling is fast and forceful, and then it stops quickly. So since that initial pattern is similar, we have to rely on the functional differences.
Which brings us to respiratory variation. This is the absolute hallmark of constriction.
This is it. This is where the physics becomes measurable with Doppler. Because the rigid pericardium isolates the heart, inspiration increases RV flow at the direct expense of LV flow. And that translates to these profound swings in the Doppler velocities.
So what are the numbers we're looking for?
In CP, for the mitral inflow, you're looking for greater than 25% variation in the peak velocity. It gets faster during expiration, slower during inspiration. And the tricuspid inflow shows the exact reverse, a greater than 40% increase in velocity in the first beat right after inspiration.
The seesaw again. The mitral and tricuspid flows are swinging in opposite directions.
Precisely. It's the echo fingerprint of interdependence. And just as importantly, RCM has no significant respiratory flow variation because that stiffness is intrinsic and constant.
But you mentioned another frightening trap, that the absence of this variation doesn't rule out CP.
Correct. Up to a third of CP patients might not show this, maybe because they're on a lot of diuretics or have other coexisting conditions. So its presence is a huge clue for CP, but its absence means you have to keep digging.
And that digging leads us to tissue Doppler and what you called the ultimate paradox, measuring the early diastolic velocity of the mitral annulus, or EMR. How does this separate muscle stiffness from an external cage?
This was the single biggest breakthrough because it measures the myocardium itself. The early velocity tells you how quickly the heart muscle is relaxing. So in RCM, the muscle fibers are stiff. That directly leads to a reduced ER velocity. It's low, often less than 7 centimeters per second. That's the classic sign of impaired relaxation.
Okay, that makes sense. But now for the paradox in constriction, the muscle itself is fine.
Exactly. Because the myocardial relaxation is preserved, the ER velocities in CP are often normal or counterintuitively paradoxically increased, even though the patient is in heart failure with high filling pressures. We call this the annulus paradoxus.
Why does that happen?
The theory is that the heart, since it's constrained from expanding sideways, overcompensates by maximizing its longitudinal motion up and down to try and achieve filling, and that boosts the measured ER velocity.
And then there's one more layer, the annulus reversus.
This is even more nuanced. In CP, the rigid pericardium seems to tether the lateral or free wall of the left ventricle more than the septal wall. This results in a reversal of the normal relationship. The medial E velocity, the one near the septum, is actually higher than the lateral E velocity. We call this the annulus reversus. This combination, a normal or high E's plus the medial being higher than the lateral, is an incredibly strong sign for CP.
It sounds like relying on just one echo measurement would be a huge mistake.
It would be a catastrophe. And that's why we have comprehensive criteria, like the ones from the Mayo Clinic. They combine all the highest yield metrics, the septal shift, the respiratory variation, the E-Rotter paradox, and the hepatic vein flow reversals. The power is in seeing all these independent markers of interdependence pointing in the same direction.
Okay, so echo gives us this incredible functional picture. But if it's still not clear, we have to move to advanced imaging and invasive catheterization. Let's start with cardiac MRI, or CMR.
CMR is exceptional. It gives you unparalleled tissue characterization and anatomy. Anatomically, both CP and RCM have big atria. But CMR can give you a simple ratio. The LA volume to RA volume is usually higher in CP, over 1.32.
But the real power of CMR is in detecting inflammation and fibrosis using delayed gadolinium enhancement, or LGE. How do those patterns differ?
The LGE pattern is the key. In CP, we use LGE to look at the pericardium itself. If the pericardium enhances, it tells you there's active inflammation or fibrosis in the sac.
And that's important for treatment.
Incredibly important. Because if a patient has new onset CP and that pericardium just lights up with LGE, it suggests the constriction might be reversible. You might try a course of anti-inflammatories before jumping to surgery. And crucially, in pure CP, the myocardium itself should have no LGE.
And in RCM?
In RCM, the LGE is in the myocardium, confirming it's a muscle disease. You see it in about a third of cases. And the pattern can be very specific. In amyloidosis, for example, the LGE is often diffuse, and it's notoriously difficult to null the myocardium, which is a telltale sign in itself.
And what about nuclear imaging? That field has seen some huge advances for RCM.
A huge game changer. I'm talking specifically about 99 milli-TC pyrophosphate scintigraphy. This has just revolutionized the diagnosis of transthyretin, or TTR, cardiac amyloidosis.
How does it work?
For reasons we're still figuring out, that TTR amyloid protein avidly binds this bone tracer. So if the heart just lights up on the scan, it allows you to non-invasively confirm this specific and now treatable cause of RCM, often without needing a biopsy. It's a massive step forward.
So despite all these incredible non-invasive tools, the paper still points to hemodynamic catheterization as the traditional gold standard. Why go through that risk if we have CMR and echo?
Because the cath lab gives you the absolute, definitive, real-time pressure measurements that nothing else can. As we said, both conditions share that elevation and equalization of diastolic pressures and that dip and plateau sign.
But the early criteria for using those pressures often failed.
They failed because they relied on static pressure differences, and there's just too much overlap. They look at the difference between LV and RV diastolic pressure, or the ratio of RV diastolic to systolic pressure. But severe RCM can mimic those findings, so the specificity was poor. They couldn't reliably separate the mechanism.
So in the modern era, how do we use the cath lab definitively?
We have to look at the respirophasic variation in pressures. We have to quantify ventricular interdependence. We use the catheter to measure that systolic discordance we talked about. We confirm, beat by beat, that during inspiration, the LV systolic pressure falls while the RV systolic pressure rises.
And there's a specific calculation for this now.
Yes, the most specific modern metric is the systolic area index. It's a calculation that basically looks at the area under the pressure curves for both ventricles over the respiratory cycle. A cutoff of greater than 1.1 has shown 97% sensitivity and 100% specificity for a constriction, is the ultimate proof of that external constraint.
So the value isn't just getting the pressure numbers, but capturing the swings in pressure that define the physics of the problem.
That is it, exactly. It is the real-time quantitative proof of the competing ventricles.
And what's the role for a biopsy, an endomyocardial biopsy?
It's not for diagnosing CP, but it's a crucial tool in RCM when the cause is unclear. It lets us get tissue to diagnose specific forms of RCM that might have targeted therapies, like sarcoidosis or light chain amyloidosis.
We've now gone through this incredibly detailed diagnostic pathway. The whole goal is to guide one single life-altering management decision. So let's talk about the pathway for CP, the potentially curable disease.
Management starts with diuretics for symptom control, but the definitive decision depends on whether the constriction is new or chronic. If it's recent, say less than 3 months, and there are signs of active inflammation, you might try a course of anti-inflammatory agents first. We call this reversible CP.
But for chronic cases, surgery is the only option.
For chronic, stable CP, the only definitive treatment is complete pericardiectomy.
And that's a radical surgery.
It is. The surgeon has to do a wide excision of that entire thickened pericardial sac, meticulously dissecting it off the heart. A successful surgery is often visible when the heart literally jumps free from the restraint once the shell is removed. It can immediately normalize filling pressures.
But the outcomes aren't always perfect. What predicts a worse outcome after surgery?
Prognosis is definitely not uniform. The outcomes are worse in patients who are older, sicker at baseline, have kidney problems, and, crucially, those with prior radiation heart disease. Those factors often hint that there's an underlying RCM component, and the surgery only fixes half the problem.
Okay, now for RCM, the muscle disease, if we confirm that diagnosis, what are the options?
They are very limited. We manage symptoms with diuretics, and we treat the underlying cause if we can find one. For example, there are now specific therapies for TTR amyloidosis, but the fundamental stiffness of the muscle usually persists.
So transplantation becomes the primary goal.
It does. For symptomatic eligible patients, cardiac transplantation is the indicated definitive treatment. Post-transplant outcomes are generally good, but again, patients with a history of radiation or amyloidosis tend to have higher mortality.
And finally, that management nightmare, the mixed physiology. If the diagnosis isn't clean, how do you decide whether to operate?
This is where it comes down to clinical judgment and having a very frank discussion with the patient about tempered expectations. If the invasive testing suggests a significant component of constriction is driving the symptoms, even if there's some muscle stiffness, you might consider pericardiectomy. But the patient has to understand that the results might be poor, especially if radiation was the cause. You might only be offering partial relief.
It sounds like the most critical future direction is just getting better at figuring out how much of the problem is constriction versus restriction in those mixed cases.
Absolutely. We need better tools, probably building on CMR and strain imaging, to quantify exactly how much of the problem is reversible versus irreversible. And of course, we urgently need novel therapies for RCM to improve the outlook for patients who aren't transplant candidates.
This has been a truly comprehensive deep dive. It really demonstrates that to tell the difference between an external constraint and an internal stiffness, you need this whole battery of tests. Moving from paradoxes on an echo screen to mathematical indices in the cath lab, all leading to one critical choice: knife or transplant.
It just showcases the incredible sophistication required to make these decisions. That entire diagnostic journey, from recognizing the annulus paradoxes to quantifying the systolic area index, it's all essential to make sure a patient gets the right treatment for their specific mechanical problems.
The one thing that came up again and again in our source material is that prior radiation therapy results in the worst outcomes for both conditions, often because it creates that tricky mixed pathology. So here's a final thought for you to consider. Given this consistently high risk, how might future advancements in localized targeted radiation delivery, things like proton therapy or advanced modulation techniques, be refined to minimize these severe cardiovascular side effects, potentially eradicating a major iatrogenic cause of this complex mixed heart failure? Thank you for watching The Funnel Effect.